Hello, my name is Olivia. I am a fourth year medical student at the University of Iowa Carver College of Medicine, and I'm applying this match cycle to anesthesiology. Our applications are due next week, so please keep me in your thoughts and prayers. Today, we're going to be doing a hematology topic on sickle cell disease. And kind of go through our typical case and exam and labs and stuff like that. And then we'll do a little lesson on sickle cell and the different complications that it can cause. Just found this little silly meme online. I don't know. I don't know why I put this here. So it's really awesome if you guys are able to participate and be engaged. So if there's any questions on the lecture that you have ideas or answers for, to either put them in the chat or you can unmute yourself and say it that way. And then if you ever yourself have any questions or something's not clear, then please don't hesitate to let me know so that we can kind of walk through it or go back to whatever we might have missed. So I'll give everybody a quick second to open up their soap note. And so our case today, we are seeing a 2-year-old boy who's presenting to clinic with his parents for a checkup and to establish care. So this boy was recently adopted from Sudan, so he's not like a biological child of these parents. And based on that, his family history is unknown, and his own personal past medical history and vaccination history is also unknown. But since his adoption, he's had 2 episodes of swollen fingers on like hotter days this past summer that have just resolved on their own. And the parents aren't really sure why, like what caused it, but they just kind of self-resolved. So what additional information or workup would you guys think of in trying to help formulate your differential diagnosis for like maybe why he had these swollen fingers, or any ideas that you have right now of what might explain that, or like things that he would be at risk for given his history? I know it's like kind of not a lot of information to go off of right now. Sometimes that is the case in medicine where patients don't have, or their parents and pediatric patients don't have a lot of background on like what brought on certain illnesses, or if they are adopted, or sometimes like in psychiatric or mental status changes, you don't have the patient to give their own history. But it looks like Cole and Ainsley are suggesting a circulatory issue. And yeah, I think that can absolutely be a thing that could explain these episodes of the swollen fingers. And we can do like further lab workup to try to figure out what that might be. So for the objective part of our exam first, so looking at his vitals, as a reminder, kids have different ranges of normal for vitals compared to adults. So compared to like myself or any of you guys, a blood pressure of 90/58 would be like pretty low and concerning that there's something happening. But for a 2-year-old, that is perfectly normal. And they tend to have lower blood pressures, higher heart rates, and higher respiratory rates compared to adults. And then for his temperature and his oxygen, those tend to be the same between adults and children. And these both look unremarkable. So overall, his vitals are not concerning for anything at his age. For the general exam, he just is looking kind of tired, but he's not in any acute distress. And then for his head and neck exam, the only significant thing was that he has this mild scleral icterus, which is a yellowing of the eyes. Does anybody know like what other medical term might be used to describe this yellowing of the eyes, or maybe if he had it in his skin, what that could be called? Yes, Rihanna said jaundice, exactly. So he's got a little bit of jaundice. Hard to know if it's like the level of jaundice is only showing up in his eyes, or if because his skin tone is darker, it doesn't sometimes like become as apparent until it's at higher levels, but he definitely has a little bit of jaundice going on right now. And then his cardiac and respiratory exams are pretty unremarkable. Important to note, like for the cardiac exam, because we were thinking a circulatory issue, that this is not like a concerning exam for any sort of murmurs or like abnormal cardiac structure or anatomy. And same with his lungs, it seems that he's breathing fine. And then for his extremities, he does not have any dactylitis present. This is the medical term for those swollen fingers that we had before. So at this time, he doesn't have those swollen fingers, and his capillary refill is normal. And that's important because if he did have a circulatory issue that was maybe causing delayed blood refill, like in his like if you were to press on your finger and you can kind of see it go white and then fill it back up with pink, that can be an indicator of like a circulatory issue, like depending on your like what part of your body you're pressing on, but his is normal. And then just to show you guys a picture of what dactylitis would look like, this is just showing kind of like the fingers and hands are more swollen. And classically, we also would call it like sausage fingers, especially in adults with like certain types of arthritis. Your joints can become swollen and your skin just gets really tight and it kind of loses its natural wrinkles and it just looks very like sausage-like. So this is an example of what dactylitis might look like of the hand, but you can get that in other places as well, like in your toes, your feet, or even like more proximally, like your arms and legs. So for our differential diagnosis, I know it's like we're kind of jumping ahead right now because we don't really have a whole lot of information, but spoiler, this is a sickle cell talk, so we're just going to kind of jump into what the different types of sickle cell disease are. So we have two different types that we would be looking at here, sickle cell trait and sickle cell anemia, and we'll kind of talk through the difference between that. But essentially, sickle cell trait is a less severe form of sickle cell disease compared to sickle cell anemia. And sickle cell disease in general is more common in people of African descent, and usually in children who are less than 5 years old. They can either be completely asymptomatic and not have any physical signs of their sickle cell disease, or they can have things like dactylitis and jaundice and fatigue, which this patient seems to all have. Based on him having jaundice and fatigue, we would also want to consider other types of hemolytic anemia. So hemolytic is meaning, if you look at the root of the word, hemo is blood, and then lytic is like a lysing process or a bursting. So when your red blood cells are getting burst open in your bloodstream and releasing like all of their internal contents, that's how you can get jaundiced, because you're releasing like heme, which is processed into bilirubin. I know it's a little complicated and I don't want you guys to worry about like the biochemical pathway of bilirubin production. That's like way beyond the scope of this, but jaundice is sometimes an physical effect of hemolytic anemia, so bursting of those red blood cells. And then with all anemias, you can get fatigue and other systemic symptoms. But with this hemolysis, you would also likely see like a dark or bloody colored urine as well, which this patient doesn't have. Not saying that like he couldn't have it, like maybe at some point he had it or he will develop it. But right now, with this dactylitis, this is pretty a good way to distinguish between sickle cell and other types of anemia. And then least likely in a 2-year-old would be like some sort of inflammatory arthropathy. So I mentioned before, dactylitis can be seen in other types of arthritis, namely like psoriatic arthritis, which is associated with psoriasis and skin changes. And so you can have like swelling of the joints in the hands that kind of come and go. And then another thing is gout, which is like a crystal arthritis of the joints and can cause, again, that really profound swelling. But in a 2-year-old, it's almost never seen like that you have kids with gout or with these other forms of arthritis. Like you think that would be a lot older, usually like 40s, 50s, 60s, and around that age group. So I would say that that's like the least likely. Okay, so now that we kind of have our differential and a couple different types of anemia is on the top of our differential, what lab tests or things would we like to order to try to narrow down our differential? Ainsley had said order a CBC. I totally agree with that. I think a CBC is a great starting point for like a lot of things. We just kind of say like CBC, BMP, like that's just our first labs that we like to order for almost anything. But especially for a possible blood disorder, we want to take a good look at their complete blood count, the CBC, and see what we can find there. Ainsley also said a CMP for liver function. Yes, I actually think that's a great idea. I don't think I included a CMP in this, but I think that in real life, that would be a very reasonable thing to look for because you would also get to see like their electrolytes and their liver labs and their bilirubin and things like that. I just didn't have that included in this talk, but in real life, that'd be a great option. So great thoughts, everybody. So we did get sorry. I forgot to delete that slide, ignore that. We did get a CBC, which showed these results here. We have low erythrocytes, this is the long name for red blood cells. So we have a low number of red blood cells. We have a low hematocrit and a low hemoglobin. Hemoglobin and hematocrit kind of go together in the sense that hemoglobin is what we really look at for anemia. And if it's below like usually around 12, but for men it's a little bit higher than women, then that would be considered anemic. And then hematocrit is another measure of your red blood cell function and quantity as well. So the fact that all of these three things are low definitely confirms that we're looking at an anemia here. And then his leukocytes, so these are your white blood cells, and those are normal. His platelets are normal. The MCV, this is your mean cyto something, like mean cell volume. So that's looking at like the size of your red blood cells, if they're bigger or smaller compared to what they're supposed to be, and that's normal. So really right here, we're just seeing like decreased red blood cell count and then decreased hemoglobin and hematocrit. So looking at his blood smear, so we got a peripheral blood smear, which is a way to look under the microscope at your red blood cells and your white blood cells and your platelets and compare the morphology of them with what's normal. So typically we like to see round red blood cells with kind of like a divot in the middle. They have kind of a donut shape to them. And they just have this nice round appearance. But as you can probably see in this patient's blood smear, they've got a couple of these banana looking or these like C-shaped sickled cells. So like there's one right here, there's another one here. This one's a little bit abnormal. This one looks pretty flat. And because, you know, these are 3D structures, like these might also have that sickled shape, but they're just at the angle that we're seeing them. It's not as apparent as this one that's like perfectly on its side. So certainly some abnormal morphology of the red blood cells. And it doesn't really look like there's any fragments of red blood cells right now, which would mean that there's been some that have had that hemolysis and that lysis that's caused them to like be broken and burst open. But sometimes you can also see those on a peripheral smear as well, where they kind of have like a mangled, like crumpled up appearance. And then lastly, we have a hemoglobin electrophoresis. And This is essentially, if you guys have ever worked in like a molecular biology lab or had a lab for your classes in college or something where you do electrophoresis, it can also be called a gel. And it's basically where you have a gel that you have little holes or wells in that you can fill with a sample, and then you run it through an electric current, and based on the charge of those molecules and the size that they are, then they can migrate through the gel and end up at like a certain point that tells us like what the protein size is and what type of protein it is. So looking at this sample here, this would be like a normal adult without sickle cell disease because they have normal adult hemoglobin or hemoglobin A, which stands for adult. We see that they just have all of their hemoglobin A up in this top area here. Whereas the person with sickle cell trait has a combination of both this hemoglobin A and the hemoglobin S, or the sickled hemoglobin. And then the person with sickle cell anemia has only this abnormal HbS, or the sickle cell hemoglobin, and they don't have any of the normal adult wild type hemoglobin. So if this was our patient here, which it is, their sample is right at this edge, then that would be a confirmation that they have sickle cell anemia. A person with sickle cell trait can also have a blood smear that looks like this. It just depends on like how much of their blood cells is affected by like how much they have of the normal adult wild type hemoglobin and the sickled hemoglobin. So if they only are showing up this sickled hemoglobin, then they for sure have sickle cell anemia. And then just to give you guys some context as well, the difference between these peptides here is really just a point mutation. In a lot of patients, it's just a glutamine to valine mutation in this polypeptide chain. And that can produce this drastically different morphology of their red blood cells. And as Ainsley said, that we would probably also have a CMP for liver function. I just didn't happen to include it in this, but I still think that would be a good idea. So for our assessment and plan, we have a 2-year-old male from Sudan with an unknown past medical history and past family history, who's presenting with remote episodes of dactylitis, those swollen fingers and hands, and mild jaundice. Labs revealed a low hemoglobin, increased hemoglobin S, and sickle cells on peripheral smear, which are consistent with sickle cell anemia. Again, with the way that we could distinguish between the sickle cell trait and sickle cell anemia would be on that electrophoresis if they had both the adult and the sickle types of protein. So our plan for this patient is going to be to start a medicine called hydroxyurea. We'll go through the mechanism of that at the end of the talk, but basically what it's going to do is it's going to decrease the production of sickled hemoglobin, or the HbS, and it's actually going to increase our fetal hemoglobin, or HbF, because it has a closer morphology to the regular adult wild type of hemoglobin, and it also has a higher affinity for binding oxygen, so it can help reduce the severity of symptoms associated with the anemia. But again, we'll go through that at the end. For this patient, because he's only 2 years old, he would qualify for getting penicillin prophylaxis, and penicillin is an antibiotic that we use to prevent infections with these bacteria. So the reason why he's going to be getting prophylaxis with this antibiotic is because you don't finish your vaccines for these until you're around 5 years old. And so we're also going to want to start him on the vaccination series for these 3 bacteria, which are Streptococcus pneumoniae, Haemophilus influenza, and meningococcus. Those are the 3 main bacteria that we worry about in patients with sickle cell anemia, because they can have decreased function of the spleen, and the spleen is really important for making us have good immunity against these specific encapsulated bacteria, meaning they have like a capsule around the bacteria that can be recognized by the immune system. I don't know, it's a lot of microbiome that we're getting into, but basically it's these three things for the plan for him. And then once he would turn 5 years old and he's finished with his vaccines, then we didn't have to give the penicillin anymore. Before we move on to the pathology, which I think will probably answer a lot of questions for people, but I just wanted to see if anyone wanted to go back to any slides or if you had any questions right now about our case and the plan for our patient. Making sense so far? Okay, and if we need to like speed up or slow down, let me know as well. All right, so we'll go into the pathology of sickle cell disease. So sickle cell is an autosomal recessive inherited disorder of red blood cell and hemoglobin morphology. So if you've taken like general biology, autosomal recessive, if you have two copies of a gene and you have a dominant and a recessive copy, the dominant one, which is like the wild type gene, typically is more like if you have two copies of it, then you can usually just get away with expressing that dominant copy. But if you happen to inherit two of the recessive genes, then you're going to be affected by that mutation. So if you are homozygous or you have two recessive copies of this abnormal hemoglobin gene, then you're going to have sickle cell anemia. And this is the most severe form, and it's also the least common. A lot more people are heterozygous, so they have one dominant and one recessive copy of the gene. And so that is going to give you sickle cell trait. So you can still have some abnormal red blood cells that are sickled cells, but you can also have regular ones, and it's more common to have this presentation, and it's also a less severe disease course. And then just for some epidemiology, sickle cell is most common in people with ancestry from Africa, but you can also have patients of any ethnicity or descent or ancestry. But the other common ones that we see are India, the Middle East, Mediterranean, especially Eastern Mediterranean, and then Caribbean and Central/South America. So it's pretty, like we see it across the world, but in Africa, it's definitely most common there. And I'm not really sure why, like we'll kind of mention a little bit later, but in Africa, there's a higher prevalence of malaria. And a fun fact is that sickle cell actually offers you some protection against malaria. So there was one hypothesis that genetically, like you at a population level select for the gene that will protect you against the like environmental threat of malaria, despite it having these other like pathologic complications that arise from having abnormal red blood cells. So that's just one idea as to why it's more common there. So looking at the different types of hemoglobin, first of all, hemoglobin is the main molecule in red blood cells that carry and bind and carry oxygen. So this normal adult hemoglobin here, which is this red line, has two alpha subunits and two beta subunits. And then it's not pictured, but it also has what's called a heme group, and that's iron, basically, that helps to coordinate these different subunits. So that's one reason why people could be anemic, is if you have iron deficiency, then you can't have enough functional hemoglobin. Hemoglobin also has this sort of sigmoidal shaped binding curve. So at like lower oxygen saturations, it's going to be able to unload oxygen more easily into your tissues. And then at higher oxygen saturations, then it can more tightly bind the oxygen and not release as much into your tissues because it has like enough already. And then fetal hemoglobin is a physiologic change in hemoglobin that as you could probably guess from the name, is seen in fetuses before babies are born, and then shortly after birth, they can still have this phenotype of hemoglobin. And instead of having an alpha and beta, it's an alpha, two alphas and two gamma subunits. And these basically, the difference is that they more tightly bind oxygen, so they have a higher affinity for oxygen. And the reason for that is when you're in utero, you don't need to be like unloading and loading oxygen as readily as you are when you're an adult, because your oxygen saturations from the placenta are like to help facilitate the fetal circulation. I don't know if that makes sense, but basically it just to know that this has a higher affinity for oxygen. And if you remember what I'd mentioned with the hydroxyurea, that we're trying to increase this fetal hemoglobin specifically because it has that higher affinity. So, and then this is just showing the difference in the binding curves here again. So like if you have the same partial pressure of oxygen, then you're going to be binding more of your hemoglobin with it, like up to 50% compared to like 20 maybe percent of the adult hemoglobin. Going back to the sickle cell disease, so the pathology for why you might have things like dactylitis is because these abnormally shaped red blood cells can cause small blockages in your vasculature, and that's called a vaso-occlusive crisis. So vaso meaning blood vessel, occlusive meaning it's blocked off, and a crisis meaning it's like resulting in some sort of physical discomfort or pathology. So normally you have just regular circle cells that are a lot more flexible and bendy, and like if you have a buildup of something, then they can kind of squeeze by. But then with these sickled cells, they are more likely to make like this blockage, and then you can't get blood to your tissues from there. This can affect multiple organ systems, including your bone in your joints. You can even have it in like your chest or your heart. That's called acute chest syndrome. We'll talk about that in a little bit. Your spleen is a big one, your brain, and your eyes and your kidneys. So really any organ or tissue, but especially the ones that have really small blood vessels and require that to function. And then, like I mentioned before, the sickled shape offers some protection against severe malaria. Malaria is a mosquito-borne parasitic infection that is endemic to certain countries, like countries in Africa, and then in other places in like Central and South America as well. And because these parasites infect your red blood cells, having a different shape can make it more difficult for them to infect your cells and to produce the effects that they have. And so that's one benefit to having sickle cell disease, is that you can maybe have some protection against malaria. So the major complications of sickle cell disease, number one, and like the most common, is having an acute pain crisis. So this would be like our patient having those episodes of dactylitis, where you have swollen fingers or hands or toes or feet. And you can also have a pain crisis in your like any bones as well. So like you can have just generalized leg pain or arm pain, or things like that. Again, just some pictures of dactylitis. This is showing more of the hands and less of the fingers, but then this is like kind of that sausage finger that we were talking about before. And again, just kind of showing the blocked off blood vessel from the sickled cells, and that's like impairing the blood flow to this area. Acute chest syndrome is blockage of one or more blood vessels in the chest. So that can happen in the heart or the lungs. And so you can have almost like heart attack like symptoms, or you can have like trouble breathing, coughing, things like that. And you can diagnose this with a chest x-ray. So this is like an abnormal area of the lung. Normally we'd want to see two pretty symmetrical, nice, clear areas of the lungs, but then this is an area that is more affected, probably because of a blocked off blood vessel. And so there's like this localized inflammation in response to that. A splenic sequestration crisis is a very life-threatening and severe complication of sickle cell disease, where one job of your spleen is to filter out your red blood cells that are abnormal. And so if you get a large amount of trapping of your red blood cells in your spleen, then you can have a very low amount of circulating blood to the rest of your body. And also because of this, you can lose your immune function of your spleen, which we said was important for immunity against those 3 bacteria, which are listed here, the strep pneumo, the H flu, and the meningococcus. And so this can increase your susceptibility to these life-threatening infections. This is a picture of your spleen. It's pretty simplified, but it's basically just showing that like this is the immune function of it. So you've got all these like T cells and B cells. You have veins and arteries that are going to help filter stuff out. And so if you get like a ton of your red blood cells that are getting stuck in your spleen, because they're being like sequestered by it for being abnormal, then you can have a loss of this immune function. So just as a reminder, the important vaccines for asplenia, or I guess like, so it's a little bit backwards because these patients do have a spleen. It's just not a functional spleen, so we call them functionally asplenic. It's a little bit confusing. So, and anybody else who also doesn't have a spleen, like maybe they had to have it surgically removed because it ruptured when they had a car accident, or for whatever other reason, again, it's very important that all of those patients have immunization against these bacteria. Another life-threatening complication of sickle cell disease is something called aplastic crisis. And this is where your bone marrow cannot produce enough blood cells in general. So that includes red blood cells, white blood cells, and platelets, resulting in severe anemia and severe like being immunocompromised and also clotting problems with your blood. So you might be more likely to have bleeding and other clotting issues. So this is an example. This is like a showing an example of your bone marrow. This is on this side, like a healthy person where you have all these stem cells that are in your bone marrow and going to be producing the rest of your blood cells. And then in an aplastic crisis, you can see this is almost all wiped out of the normal stem cells, and it's replaced by a bunch of fat cells that's like these white sort of bubbly things. And so on a lab finding for an aplastic crisis, you would see on like a CBC, a low red blood cell count, a low white blood cell count, and low platelets. So that's called pancytopenia, where everything is low. Okay, and then lastly, just stroke is another risk of sickle cell disease and other central nervous system problems. But those 4 that we talked about are kind of the main complications of sickle cell disease that you really have to know and look out for in your patients with sickle cell, and be able to recognize them right away and make sure that they are treated so that they don't have like life-threatening complications from them. Chronic complications, which, so like these are not as acute and life-threatening, but can certainly be debilitating for patients. So hemolysis is this shearing and bursting of the red blood cells in your blood vessels, causing painless jaundice, which is that yellowing of the eyes and skin. That can happen in patients more with like sickle cell trait, and sickle cell trait is less likely to have those other major complications we talked about. And then your retina of your eye and your kidneys both are areas of the body that have very, very tiny, tiny blood vessels that are super important in the functioning of those organs. So if you have you know, a buildup of your sickled cells in those areas, then you can get impairment of the function of those tissues. So this can lead to vision problems for retinopathy and kidney problems for nephropathy. So it's important to just keep up on general health maintenance and do regular eye exams on these patients with sickle cell disease to make sure that they are not progressively being impaired and going untreated for a long period of time when they might not be symptomatic at the beginning, but that it can really affect them down the road. So kind of going over this treatment again, hydroxyurea is the primary disease modifying drug that we give patients, meaning that it can actually change their hemoglobin type that they're producing to reduce the severity of their symptoms. So, like I mentioned before, it's going to be increasing the production of fetal hemoglobin. It seems a little weird, like it's not going back to regular adult hemoglobin. And I'm actually not entirely sure of why that is, but I do know that it's part of the reason is because of this increased binding capacity of fetal hemoglobin for oxygen. And it's certainly higher than the sickle cell hemoglobin, like the HbS. Less common treatment that's like disease modifying is a bone marrow transplant. If you can get like genetically normal wild type stem cells in your bone marrow to produce regular red blood cells and hemoglobin, then hypothetically you could like continue producing these normal cells well after you are like you get the transplant. But that's less common. I'm not sure if it's because it's not as well studied or if it's just not as efficacious, like it doesn't have a high success rate. There's probably lots of reasons why it's not as mainstream, but it is one option. And then something that's not currently available, but that's being studied and is looking like a promising option is doing gene therapy. So that's actually going in and fixing that point mutation that's causing the mutation of the hemoglobin and allowing your body to then produce the correct protein. Again, I don't think that that's on the market and being used in actual patients, but it's in like studies right now. In really severe cases, patients who are in one of those crises or they're extremely symptomatic from their anemia, then you might have to do a transfusion exchange therapy. And that's basically taking out a good bulk of their normal blood that has a lot of those sickled cells. And then you're replacing it with normal appearance and normal morphology donor red blood cells. And so that can provide kind of a temporary fix because the lifespan of a red cell is only 120 days or less. And after the blood has been donated and it's put into storage and however long that that's been there, that just again reduces the lifespan of the red blood cells. So it's not used in everyone, it's just in people who really need it. For prevention of complications, vaccines is one of the most important things you can do. Here's those three main bacteria again, the Streptococcus, the Haemophilus, and the Meningococcus. These two are really like big culprits of pneumonia and of like head and neck type infections of the respiratory tract. And then meningococcus is the primary organism that causes meningitis. So they can be really, really life-threatening and high morbidity mortality infections. So we prevent it with vaccines, and then also in children or people who cannot have the vaccines or are not complete with their series, we give prophylactic penicillin antibiotics to try and prevent these infections as well. I guess before we move on, any questions about the pathology or the treatment of sickle cell or any of the complications that we talked about? Okay, and then for the quiz after we're done with the talk, if anybody needs to go back to any of these slides, I'm happy to go over some of this stuff again. So for a patient update, he is now 4 years old. He's in preschool. He's doing well, and he wants to be a race car driver. I think that's always one of the most fun things in pediatrics is like just talking to the kids, see how they're doing. They're really fun to be around and to talk to and to see how they change and grow over time. So our patient is taking his hydroxyurea and penicillin, and his vaccination series will be complete next year, so then he won't have to be on the penicillin anymore. He has had to go to the ER once for an additional dactylitis, but he has not had any of those life-threatening complications or required any transfusions, so that's good. And then lastly, I kind of always like to have a little overview of the specialty that we talked about today. So for hematology, a lot of the things that they do are learning about the physiology and pathology of tissues like the blood, bone marrow, immune system, and even cancer. So to be a hematologist, a lot of the time you do a combined fellowship with oncology, which is the treatment of cancer. And so I think that you probably can only practice hematology. In fact, I've worked with people who only treat patients with blood disorders and not with cancer. So you can do it. You just have to get training in both. So examples of things that hematologists might treat would be anemia, coagulation disorders, blood cancers, hemophilia, and things like that. I think that being a hematologist or an oncologist, if you're both of them, is a cool position to be in because you see a patient for the first time with an acute problem, oh, they just were diagnosed with hemophilia at birth in their newborn screen, and they have to be followed for the rest of their life. So you help kind of stabilize and work on their treatment regimen, and then you kind of have that continuity with them and follow up for a really long period of time. With hematology, so this is a subspecialty of either internal medicine or pediatrics. So you can work with either kids or adults. And you can also work in both an inpatient and a clinic setting. So if you just want to do follow-up visits with people who are pretty stable and be mostly in clinic, or you can work with people who are in more of these big crises and who require inpatient treatment and maybe some procedures like bone marrow transplants and things like that, then you can do inpatient. So to become a hematologist, you have to do 4 years of medical school in the US. That's going to be either an MD or DO. And then you would do a residency in either pediatrics if you want to work with kids, or internal medicine if you want to work with adults. So that's where you kind of have to choose if you want to do kids or adults. And then your hematology oncology fellowship would be another 3 years after residency. And those two things are usually combined together. But like I said, if you have specifically interest in just hematology, you can only work with patients with blood disorders, or even on the other side, you only want to treat people with cancer, then you can do oncology only as well. Those are my sources. So that's pretty much it for this case today. I'll give you guys some time to work on the quiz and the SOAP note. If you have to go back to anything or wanted to see a different slide that we saw before, let me know and we can kind of work through that together. And please leave feedback at the end of the SOAP note as well. That really helps me pick future topics and lets me know what you guys are interested in for learning future virtual rounds. So let us know how we did. And if not, I'll be taking any questions that you guys might have and be available for the rest of until you're all done. So thank you for coming tonight. And let me know if you have any questions.